Hi, Emily. Welcome to the Long COVID Hope podcast. It's really great to have you here.
Hi, Sarah. Thanks for having me.
And I'll just introduce the book. Today we have it's a little bit different from our usual Long COVID Hope podcast sessions. A little bit of a different take, I suppose. Because today Emily Mendenhall is here to talk about her new book, Invisible Illness: A History from Hysteria to Long COVID, which I avidly read cover to cover, and I totally loved. Emily, would you like to just quickly introduce yourself?
Yes, sure. Hi, I'm Emily. I'm a medical anthropologist and professor at Georgetown University. Um, for 2 decades, I studied the interplay of trauma and diabetes and thinking about how distress in your life as can contribute to chronic illness and how we can't think about chronic illness without thinking about the complexities we live with, which is often multiple viruses or infections or metabolic conditions, but also our social lives that become embedded. And this was written in a few books, Syndemic Suffering, Rethinking Diabetes, recently Savoring Care, How We Live Well with Diabetes. And then during COVID, I just got really involved in COVID politics, and I wrote a book called Unmasked, which was about whiteness and COVID denialism in rural Iowa, where I grew up. My brother-in-law was leading the response. And it was, we spent time there during COVID, and it was so dramatically justified from my life in DC, where everyone was really cautious. So writing about those differences in America was really interesting. And then I had a student who got really, really sick with long COVID. And instead of dropping out of school, I kind of supported him and encouraged him to um, I'm an anthropologist, so field notes and do an autoethnography of his own experience. And he just like really intensely journaled his experience and then started to recover and we did a study together. And then I ended up doing a longer study once I got a Guggenheim Fellowship, which gave me some time to think and read and really go into the history and the complexities. And I think you and all of your listeners probably know when you start thinking about long COVID, it starts opening up all of these other aspects of how recovery, but also suffering and how complex, how long COVID is not a single story, and it actually is part of a longer history. So became very interested in that. So that's the quick story of my background.
It's quite a big introduction, and obviously, obviously you've written so many books and you've done so many things, so much for you to talk about. And maybe you touched on my first question already, but I just want to say before we jump into it that I just want to say thank you for writing this book, quite honestly. As someone who's, I think I've experienced eight of the conditions that you put in your glossary. So it's very
Oh, wow.
vindicating to, yeah, as someone who's had a lot of invisible illness. It's just like I read through this book, like vigorously knocking in my head and like, yes, yes, yes. And yeah, I just yeah, I don't I get a lot of requests to be very honest for people to come on and promote X, Y, and Z on this podcast, and most of the time I just decline. But for one, like I just really believe in this book, and I think it's just thrilling that you wrote it. So thank you for writing this book.
Thanks so much,
But
Sarah.
yeah, yeah, so I just wanted to just ask about like what led you into this, and I guess you touched on it that you had a student that was ill with long COVID. Like what
Yeah.
led you down this road of writing this book?
Yeah. Well, I also, after he was sick for about a year, I got my first, I was infected in 2023, or 2023. And I got, all of I have an anxiety disorder and it just got out of control like it never had been. And my fatigue got really intense. And it took me about 6 months to kind of recover, not even to baseline. I don't think you ever go back to baseline in some ways because now whenever I get an infection, although I feel normal most of the time, but it takes me just a long time to recover. So I mean, I don't actually identify with having long COVID, but my biology has changed. Now, also maybe it's perimenopause. Let's be honest, but our bodies are changing and shifting. But I think it's really hard to pinpoint one thing that brought me to write this book because I've always really been passionate about women's health. And I think when I started thinking about post-viral syndromes and the complexities of our bodies, I felt like thinking about them in a new way, I felt like the things I've listened to hundreds of women's stories about living with chronic illness from 30s to 70s for 20 years. But I felt listening to women's stories with long COVID or endometriosis or chronic Lyme or, all of these conditions, Ehlers-Danlos syndrome, and then, many conditions I don't even talk about in the book, like especially after having, children and your body's change and just not being recognized for your pain. I felt like I had really missed some really critical work or just signs in my previous work. And I just became really passionate about what that meant and how, if someone who has been really committed to women's health and inequity and really giving time and space to women's health, that I felt like I missed these signs of post-viral syndrome. Like it's clearly just the anthropologist. I mean, it's not even being visibly understood or discussed in medicine. And it made me really, really interested, but also pretty concerned. So the book is somewhat an advocacy book. It's a tool. And it's a tool to legitimate women's suffering or women's bodies and the complexities that we have and the kind of severity of medicine and discounting them. And it just felt very personal and urgent.
Yes, yes, yes. Yeah, I wanted to ask you about because you mentioned in the book about having kind of a mild version of long COVID and you'd experience post-viral fatigue and a few things. But it's interesting, isn't it? Because like obviously you've spoken to a lot of people who are struggling with long COVID, and so like comparatively, like what you went through must seem much like minor or less than like people that have been struggling with 25, 30 symptoms for years now. But I
Yeah.
think it's important to acknowledge that like that you did have that experience of the post-viral fatigue and you did go through that yourself. And I think like it reminds me of my mum actually, because my mum she watched me go through long COVID and she actually in 2022 she got COVID and her sense of smell and her sense of taste never returned. And obviously, I know that that's two symptoms from a long COVID, but she would never describe herself
Yeah.
as being a long haul or anything like that, despite the fact that I'm fully well and she has never got over that. So
Yeah.
it's just an
Well,
interesting point.
yeah, that is so important and I think naming really matters. But I do feel like for me, I was thinking through a disability lens in such an extraordinary way. And like my disability, I've been dealing with, I mean, living with anxiety. And I've actually talked to a bunch of friends who have other sorts of manageable mental health conditions or other things. And they're like, I never actually identify with having a disability ever. And now I feel like maybe I have the permission to. And I think if we think about terms of access points, and I write about this in the book, and my friend and colleague Amy Kelly really brought it up to me, and she was like, "Well, an access point might be a medication in one place, it might be a wheelchair in another, and the visibility of it can really affect how you live in the world with your disability." Um,
Mhm.
and I don't know, thinking about that really matters. And I think I like how you framed this because really talking about what it means to be affected and the legitimacy of that effect is important.
Yes, absolutely. And so, okay, so we'll dive into history then, because it is like a social history of like all chronic illness from all time. And like, to be fair, like my mind was blown various times reading this. I mean, I do understand some of the history about hysteria or things like that, but like to actually kind of you really lay it out so clearly and like you articulate it so well. And like, so you track the lineage from hysteria to long COVID. And I had no idea that his hysteria actually meant uterus, which kind of was like, what? But here we are.
Here we are.
Like, yeah, do you want to just explain, like, describe to listeners like where you started from and and actually it goes way, way earlier than that too, from like Hi Hippocrates, like, so the
I
really
think,
long history of,
yeah, I think it's so important to just think about how long misogyny in spheres of health and medicine have played out in how our bodies are interpreted. And that's kind of why I went all the way back because I was like, long COVID is a moment in a long history, and so often the social experiences we have are embedded in so much history and we don't necessarily have access to it. So, I mean, even this is like a part of the history. I tried to tell a story that really threaded everything together because And one of the things I really pulled out of the history, there's different ways that you can rate this story and explain the kind of misogyny in medicine and how frames of hysteria and neurasthenia have really been gendered and dismissive of real physical pain. Is, every time a condition was identified in the body, MS is the best example. All of a sudden, people with MS were always I relegated to the hysteria construct and saying, oh, these people have hysteria. But when they actually found physical plaques in the brain that could be measured to identify that someone had MS, all of a sudden it was a biomedical category, even though, like other conditions, there wasn't a clear treatment. And that changed the experience of patients in radical ways because all of a sudden they were believed that it wasn't in their head that there was really a physical manifestation and they weren't making it up and that they should be cared for in a deeply respectful way. So, yeah, historically, thinking about how these frames were really weaponized against women, um, is really problematic. It still makes me think about how little research is really done on our neuroimmunology. And it's one of the reasons why I think so many of these conditions remain kind of floating or unexplainable, is because we just simply don't take them as seriously as others.
Yeah, it's just like a like for thousands of years almost like a failing of traditional medicine or traditional science as well, like scientific research to actually look into these very valid, very real conditions. And
Yeah.
yeah, it totally blew my mind.
Yeah.
Like when you when you wrote that like the first known like long flu that someone that had like a post-viral experience from flu was 412 BC. Like my mind exploded at that point. Because like I was from the first wave of long COVID, and I would go to the GP, and time and again, like my doctor was like, "Oh, I don't know, we've no idea what this is," and it's just like, well, actually, you should know because post-viral like syndromes have been a thing. They should know this. They should know.
It reminds us again about like how medicine in the US and the UK is really framed as like our bodies are machines and this is how you fix them. And it really reminds us that these kind of lingering, less visible conditions, endometriosis, I thought was really critical to have in the book actually because it's not viral, but it is something that's really hard to detect and it is incredibly disabling and painful and takes 6 to 8 years for diagnosis. And people are just dismissed again. You're not really in pain. Oh, it's just, you know, you're just being emotional. Well, literally, you have physical tissues moving in your body and disrupting your, your symbiosis and, really causing disruption on different organs. And you're just completely dismissed for years. And it's just another good example of how women, especially women of color, are not believed in medicine and how, and especially lower income people. I mean, wealthy white women particularly have been centered as these, indicate, obviously, kind of like yuppie flu or like kind of like dismissing these as like whining women. But we know even those women are, us really are those who have had visibility because we have some sense of power linked to our social identities or our racial categories. But thinking about people, especially who are low income or people of color or who have, other social identities, maybe, don't have secure insurance or, several different identities being also living with a disability can be further marginalized and completely dismissed linked to these conditions, especially when they're hidden behind other conditions that people are needing care for. And I think it's really important to recognize that because, um, when I worked with Mexican immigrant women in Chicago specifically, especially who are undocumented, I wrote about this pretty extensively about how having a diagnosis of diabetes could make you, could be your in to access. And I know the US has a really fucked up health system and it's very different than the UK, but being able to access and understand that you have, you can get healthcare through this one diagnosis, even though your other conditions may be ignored or never recognized. But what does it mean to not be recognized and fully cared for? Well, what happens is that a lot of women are blamed for their other conditions. You're not eating well, you're not, following our recommendations, and you're making yourself sicker. So really just having a conversation about what we don't know and how the body isn't just a machine to be fixed feels, just incredibly urgent in this time when there's so much uncertainty.
Yeah, absolutely. And like obviously with the gender gap and this whole hysteria thing and the fact that so many of these conditions were originally called like emotional or it's psychological. Like why do you think that medicine through history and probably still today, like why the default is to jump to it being, oh, it must be psychological. Like, you know what I mean? Why do you
I
think
mean, I
that
think it is.
is?
I think it is linked to how little we know about women's neuroimmunology and how our bodies function. I mean, how our hormonal systems change. Even like right now, everyone's talking about menopause. We're all writing about, I feel like in the public sphere at least, and especially among feminist circles, people are like, what's happening with menopause? Maybe it's our generation who's really talking about it. But I think for so long, women's hormonal or like physical transitions and transformations in life have been really pushed down. Maybe not among sisters or close friends, but in the social sphere and recognizing how fundamental that is in our healthcare and how caring for people throughout life as they're shifting really needs to take that into consideration. And to think about how we are just so we have different needs. And I
Mhm.
really do think it comes to our little understanding of how to balance and live through these transitions as women in medicine because it's so male
Yeah.
dominated still.
I do wonder if there is a pattern, a relationship between COVID infections, possibly long COVID, and early perimenopause. Like, I don't know if you can speak to that at all, but there's something that I've been witnessing time and time again that like long haulers and people that have had a lot of COVID infections are beginning menopause or perimenopause like much earlier than their doctors expect them to. Like,
I mean, we don't know, but I think that's a really
yeah.
interesting question. And I think one part of that answer is that people are dismissed like you don't have long COVID, it's just perimenopause.
Mm,
And on the other hand, you may be going through perimenopause, which is amplified or maybe making it earlier, who knows, by this infection. But I think the important framework for thinking about long COVID is and this is what I argue in the book with this theory of thresholds, is that it amplifies the virus, the infection, especially if you have other viruses like herpes simplex, or you have Epstein-Barr virus or another kind of underlying genetic vulnerability, or maybe a bacterial infection that will actually possibly amplify the effect of a COVID infection. And I think that we know that, and what I argue is, especially those who've become really sick, would say that whatever is amplified, like in my case, my anxiety disorder was amplified. But for so many people, like if you have an undercurrent heart condition, COVID could amplify that, right? It could reveal your suffering that's already existing and bring it to the surface. So and this is actually a physician who was a long distance runner who got really sick. Who I cite in the book, she calls it a fire, just waiting to be inflamed. Um, and I think that's a really, really good metaphor. And actually, Mike Van Elzeker, a neuroimmunologist who writes about long COVID and does a lot of work out of polybio, bio-focused work, also kind of made a metaphor of it's like unpeeling an onion, of unveiling, kind of what's layered below and what kind of vulnerabilities we have. So your comment of like, is it amplifying perimenopause? Possibly because it's weakening the immune system and it's creating this biological vulnerability for ill health.
thank you for that. Yes. Really good point. So you say in the book that long COVID, you call it a watershed moment for unvariable post-viral conditions. Could you explain what you mean by that? It's a strong
Yeah.
statement.
Yeah, well, I think it's a watershed moment, I actually think, for the disability movement too. But it was
Yes.
a watershed moment because so many people, for the first time, were stuck in their homes and fearful that a virus could be disabling for them and disrupt their lives completely. And I think a lot of able-bodied people had never been in that position. And it really made some people angry, really angry, around the world that they had this vulnerability that they couldn't go or that they didn't believe it. But the physical kind of restriction created, I mean, there's so many people who are living with disabilities and they can't live in our environments well. And so they do not leave their homes, right? Because they are fearful of infection. The environment they live in isn't supportive for them to live well. Um, and so, really bringing to the surface what this meant, but it also meant that, at a moment when everyone around the world was infected with this one virus, all of these people got sick. It made it very visible. The pandemic was very visible. And then people started to really experiencing these long COVID symptoms. So everyone was talking about it all the time. And it wasn't just that this happened, but we also had these incredible activists who were really bringing it out. And I think the activists made a huge impact on how we think and recognize long COVID, and were really powerful. Elisa Parego, I mean, even named long COVID on Twitter, and that is a very powerful statement and movement for long COVID activists to do. It really was transformational. We've never seen that before, and that was really cool. And it was a very feminist movement too, which was awesome.
Yes, yes. You talk in the book about, you explain about body politic and the Slack community, and I was a part of a member of that, by the way. I found Fiona's
Amazing.
article like really early on, when she wrote an article in the Atlantic, which is just like, it was something like, I caught COVID and then never felt better, and I'm like, oh yeah, that's me. And that's how I found the body politic movement. And yeah, we kind of like group together out of necessity, but also there's something like very powerful in that, and the way that we as patients really stood up and said, you need to listen, like this is real. We were all really struggling here and people need to start, paying attention, sort of thing.
So here's
Yeah.
a question for you. One of the things I talk about in the book is access intimacy, which is really talking about how people manage their new lives living with disability and the intimacy and legitimacy that you get, through these online communities. And I'd love to learn more about what it was like with body politic at that time, if you wouldn't mind sharing.
I mean,
Just
I mean, body politic for me was a complete lifeline. Like, I don't know what I would have done if I hadn't found that community. Like, it was, yeah, I might start crying actually. Like, it was so supportive and just so reassuring that there were other people out there, and you could just speak to them in real time that were going through the same thing. And it was it's such a shame that due to funding, they had to shut it all down and all of that got disbanded, because it was an amazing resource of information. It was grouped really carefully. Like, obviously, they put so much care and attention into kind of making the information, um, creating the information, and also ensuring that it was a safe space and all that good stuff. Like, where I think these days we lack that kind of safe space, like online community. I mean, obviously there's pockets all over the place on Reddit, like on Twitter a little bit. It's different. But like that was just such as like a safe space, like caring community, and we just supported each other. And like I found out that I had POTS and dysautonomia possibly years before I would have done through any other method.
Mhm.
Because I found I connected the dots on Slack, what people were saying, and I was like, yeah, this sounds like me. And then I could go take that information to my doctor and advocate for myself to have a sit-stand test and everything. And like, yeah, like, yeah, without body politic, I'm actually not sure, how rapidly I would have recovered, if at all, without that support. So yeah, yeah.
Well, and it's actually really important. I loved talking and learning about body politic, and I kind of saw it early on happening. But I really think it's important to talk about body politic as not like something that came from nothing, and that's what I tried to
Mm,
do from in the book is start with the HIV AIDS activism and think about how ACT UP in the US really actually started to foster some of these techniques for responding to the medical establishment that was maybe, misguided or ignoring patient needs and how to advocate for yourself for an illness that people don't understand. And because people from ACT UP were engaged with body politic, and body politic itself was like a queer feminist space working for well-being among people living with disabilities. And so
mhm.
that kind of orientation already was rooted in the disability justice movement and racial injustice um, programs and movements. So I think rooting it within these existing patient frameworks and leaning on the expertise of the ME CFS community in particular was really radical and influential and positive.
Absolutely. And yeah, we were like standing on the shoulders of people, who have had MECFS for decades and, etc. And the fact they were advocate like giving us information that was helping us, telling us
Yeah.
to like pace, to stop pushing and things like that. Like, yeah, it's all a part of this bigger picture
Yeah.
of this like a watershed moment, like you describe it as. And like, like, so obviously this is the Hope podcast. Like, what do you think gives you the most hope, like that the era of long COVID will be some sort of turning point for traditional medicine? Like when finally listening to the patient, maybe like I don't know. Are you hopeful? I do feel hopeful myself, but yeah,
I mean,
well,
I think part of the journey, at least for me going into the clinic, is recognizing blind spots. So you
mm,
were just talking about how body politic itself just gave you confidence and awareness of conditions that people don't talk about. I mean, these kind of conditions are not talked about in medical school. They're not on the exams because the exams are about the mechanics of a body. You know, the body is a machine. How do you fix this? How is it connected? Like, what does it do? But really thinking about the less visible aspects of dysregulation is not part of biomedicine, Western biomedicine. So really pushing the envelope on that and also recognizing, I think pushing against the hegemony of medicine is really hard, really, really important. But the hopeful part is that we can, and that we can also make choices when medicine is harmful and saying, this is not helping me. This is not, they are not listening to me. And in the UK, you have a different system. In places, in the US, we're very profit driven. And
mm,
so, we're not patient centered in the least. And so, really thinking about how to reframe and call for more patient centered care is really critical. And saying, we actually know what can work for us. We know what we need. This is what we need. And I actually really believe it's going to require full scale. I mean, the book is very US centric, but it's going to require full scale change
mhm.
and a radical transformation in how we care for people as people. But this is a long time coming. I mean, our profit-driven system is going to explode, and people are already really angry with how it is. And so I think that we're seeing
Yeah.
these alternative types of models. And Elba Azola, who is a physician at Johns Hopkins University and just a brilliant kind of thinker and advocate for long COVID patients, that I wrote this piece in a new publication I have called Science Politics, which everyone should read. It's really cool. Sciencepolitics.org. Um, but we write about what long COVID clinics could be and how they would look, and really going into a clinic that has all of the things you need, a rheumatologist or a neurologist, along with your primary care doctor, and a social worker to help you through your paperwork, and a lawyer on staff who can help you get
Mm,
disability or manage any other legal issues you need. Like if you need someone to intervene to make sure you can keep your house or, deal with a landlord or, whatever it is, really having these interdisciplinary teams available to enable patients can advocate for themselves. Because if the system is broken, you actually just have to I mean, to manage, you have to have the tools available. And one of the things I
mhm.
found is that when people were able to get disability, they were able to stall their rent, or they were able to get support financially, they were able to do better all through their life. And, that's just such a critical thing to remember, is that, some people are suffering tenfold because of that financial instability and insecurity, or
Yes.
not having someone to care for them who's being loving and understanding.
Yes, 100%. Yeah, I did notice that your book is obviously, more US focused. Fair. Obviously you have to have a scope for
Well,
your
I'm an
research.
anthropologist, so
Um,
I actually did have quite a few stories of people I interviewed from here. I actually have done some work in Kenya on long COVID too, which has really been
right.
awesome.
Cool. Yeah,
With
yeah.
some colleague, a really close colleague of mine, Edna Basire. But it is just such a culturally constructed health system linked experience that I
Mm,
felt like I actually did have stories from elsewhere, and then I actually cut them all out because I felt like it was too much. It was like distracting from this one narrative. But I
mm,
think you could write a
mm.
similar book, in each country, but it's very different experience based on your healthcare. I mean, the US health system
Yeah,
is quite oppressive. And it plays a huge role in how people do well. And I mean, the fact of the matter is people who had money did better. And that's how the American
yeah.
experience is.
I mean, yeah, I completely understand. Like, I mean, the NHS in the UK has like 99 problems, but the profit motive isn't one of them.
Yeah,
Funding is.
yeah,
But yeah, but I completely understand where you're coming from in terms of how broken things are in the US in particular around the health insurance model and people like not be able to get care at all because they don't have insurance, and that's totally messed up in my opinion. But like I think that all Western medicine model, like in any country, like still has this fundamental issue that like with conditions like this, it's so multi-systemic and that they have these silos where you have to go to
absolutely.
cardiology for this and respiratory for that and neurology, and it's just completely ridiculous and not useful at all. And actually, what you were just saying about the vision of like a future long COVID clinic or a clinic like this, it reminds me of my favorite passage in your book, actually, which I'll tell you what it is. Because yeah, like it's in the section where you're talking about Peter and so yeah, Peter Brown. One of your colleagues and friends, who got, I might pronounce this wrong, Guillain-Barré syndrome, is it?
Very, yeah, yeah.
Barry. Okay, yeah. And how you visited this place where obviously people were receiving, yeah, the critical intensive care unit and rehabilitation center receiving excellent care. When you're looking around and there was only one woman, a patient in the room, and you were saying that like you're wondering how disability is measured and like how do you prove you're disabled enough to be worthy of this sort of care? But then you go on to say like you have like this you imagine a rehabilitation facility for those living with a chronic condition. I'm reading directly from the book, by the way. And you said you imagine quiet rooms for meditation, steam rooms, sound therapy, massage, strength training, a warm pool for imagining how to move freely again. I just loved this passage, and I just like, yeah, like can we like, imagine a future where we are better supporting, these community of patients and like, yeah, like actually helping them to fully recover. You know what I mean? Like, yeah, you're just preaching to the choir with this passage. I
Yeah,
don't, I don't know. Yeah.
but I do think it is going to take a community of people, probably women, um, really pushing for this. I mean, and I imagine something even broader, actually. In the US, we have the YMCA's. I mean, I have lived in London, and I had a baby in London at the Whittington Hospital.
All
So
right.
I know a bit about the health system there. And one of the things that's so nice is that there's surgery. There's like a community health center essentially in every community where you can go to the doctor. It's quite easy
Mm.
to go there. It's quite accessible, and you're not paying co-pays and out of pocket every time you go, so you're not thinking about money to go see your doctor. But what I imagine, and there's also a school in every community in the US because of our founding, we never imagined health would be as important as a school. So we have public schools, but not public health centers like you do. But what I imagine as an ideal thing in the US is building, and I think it'd be very simple to do this in the UK, maybe, I mean, if the financing was there, but is to imagine a YMCA or we have these like rec centers where you go and there is a pool and there is an exercise place and there is a little place for people to work and there is a child care center. But what if we also had a health center? And it can be run by PAs, it can be run by family nurse practitioners. It doesn't need to be run by people like physicians, with MDs necessarily at all. We need a psychologist on board. We need a nutritionist. We need, there's several things that we can do to put community health at the center, where it is also linked to where people can, work on their rehabilitation. Because I mean, I know that after having my second child in the US, so I had two very different birth experiences. I was really, really in pain. I had really bad sciatica, and I couldn't go to physical therapy because, quite frankly, I couldn't afford it. I couldn't afford to drive an hour across town to go to the physical therapist who took my insurance and drive back and do work and be a mom. I couldn't do it. So, thinking about how difficult it is because of our financing system and because of our lack of imagination, I mean, we can do this. We just need to do it. We need to have, people leading this. I mean, this is not something I can do. I don't know how, I don't understand the business world in that way, but I know that we can do this and create these community centers that are, fulfilling, where we have, you know, you should be able to go and have a wellness exam without having to worry about your toddler
Mhm.
while you're getting, senior
Yes.
gynecologist, which I have to say I've done. I have, done that. We all have, dealing with different types of caregiving while we need to take care of ourselves and often putting ourselves on the back burner, which only amplifies our chronic symptoms that become, you're just consistently pushing your own needs to the back. But if we had a community health center that was really focused on health and wellness and well-being, I think it could be really transformational if that's where the clinics were.
Yes, amen to that. I hope pe people that can affect this kind of change and implement this that are listening. You know,
Yeah.
I can supply the yoga meditation aspect, but you know what I mean. But yeah, like we need people with to see the vision and also know how to implement it. But yeah, I think that's yeah, I loved that passage in your book.
Oh, thank you so much.
Um, yeah. Okay, I'm aware of time. Oh, okay. So one biggie that I enjoyed in your book was talking about like hustle culture and the conflict between obviously in our contemporary late capitalist, very workaholic culture, like how to what degree is having an invisible illness like more traumatic and harder than it might be if people were allowed to actually rest and recover. You know what I mean?
Yeah, and I actually think this is where neurasthenia and frames of earlier types of post-viral or complex chronic illnesses that were framed as being linked to culture in general really kind of resonates to this, because I
Mm.
think that in UK, US culture in general, this idea of always doing and always succeeding and always producing has been really disabling for people. I mean, it's a lot of disability scholars who have written about living with a disability, for example, in this cultural context, indicates that it is literally the disabling culture that makes it hard to live. And part of that is our lack of recognizing that you really do need to rest. I know that, like, when do you have time to rest? And I was just having a talk with my sister about how our generation was kind of lied to that we could have it all, that we could work, we could have these full-time jobs, we could be full-time moms, we can, do all of this stuff, like live this life that was completely imagined. And I mean, I have like no help. I have like no family besides my cousin who
Mhm.
also has a kid, in DC. My family lives far away. And I think that we were sold this fiction. So when our health gives out, there's no time to rest and recover and repair. That's not built into our structural system, and that's not built into our cultural system. So this idea of always producing is completely disabling um, for all of us. And I think if we were able to shift structurally, that's why this kind of imagined center where we have healthcare, but also like all of the wellness stuff that we need. That is a really powerful orientation that's in every community, could be so transformational because it would normalize, putting your health at the center in a way that isn't currently done.
Yeah, amazing. I mean, we almost need like a restructuring of like, well, most things, I suppose. But like people just need to be able to have like a village to, to care like in times when people are at low ebb and need that support. Like, yeah,
Yeah.
100%.
Yeah, I have a friend, I have a colleague, Emily Store, who's this brilliant anthropologist, and she was like, I don't want to have this single family home or like these independent apartments or like I don't need to live far from people. I want a communal kitchen. I'll do Monday, Tuesday I'll watch the kids. The other days I can do what I want. Let's come back and like recreate these kin-centered economies where we are truly helping each other because this is how we could do it. If we collectively, share and support each other in these deep ways, we can do this. But in the current system, we can't. I
Yeah.
don't know. I like,
Mm. Or just to set the world to rights.
yeah.
All right. So speaking to the listeners here, like what if like if you could give one message that you could take away or one historical truth that you've uncovered or whatever that they can carry in to their next conversation, with a difficult family member who doesn't understand or a doctor who's been gaslighting them, like what would you suggest that is?
Well, actually, my cousin is a family doc, and he said, you know what, I have a really hard time helping people with complex chronic illness because it's hard to diagnose. They don't always know what to do. So now I just give them a copy of your book. And I'm like, oh my God, I love that. He's like, I just have like 20 copies on my counter. I like pass them out. But I do hope the book is an advocacy book, and I've gotten so many lovely messages from people saying like I feel so validated after reading this book. I feel like I have some next steps. Also, if you have someone who doesn't believe you, give them a copy of the book. Say like just please spend time with this. And I wrote it very carefully to ensure that because there's lots of ways to write about this. And I wrote it very carefully so physicians would take it very seriously because I know some clinicians just seriously don't believe something like chronic fatigue syndrome or ME/CFS or long COVID are real. They still don't. Um, and because they don't understand it, it's not something they've been trained for, and it's not something that can be easily fixed. But if someone is feeling and really innate, I mean, you know your body, you innately know if something's off. So being able to advocate for yourself can be really hard. And that's why one of the reasons I wrote the book is just to be able to share and say, this is a very, very long, there's a very long history of ignoring women's truth. So please take it seriously. This is what we can do. And this is the realities that we're facing.
Yes. Thank you so much. It's been an absolute pleasure to have you on the podcast. And yeah, I do recommend that anybody listening to go grab a copy and yeah, sure, send it to their physician as well or
Yeah.
anybody that needs to hear this information. Yeah, it's written really well because it is both easy to read to like the layperson who's not an academic or a doctor, but at the same time, a doctor, like you said, can read it and it's like authoritative enough, and there's like, a huge amount of references that they can go, read and find out where this information is coming from. But yeah, I love it, and I'm just so glad that you shared it with me, and thank you so much.
Thanks for having me. This is a great podcast, and I just really respect you and appreciate what you're doing.
Thank you.
Thank you for listening to the Long COVID Hope podcast. We sincerely hope that you've enjoyed this episode. Please note that we are not medical professionals and this does not constitute medical advice. Always speak to your doctor or medical professional before starting any new treatments, supplements, or new exercise routine. If you would like to support the podcast, please do me a favor and give a 5-star rating and review and subscribe to the podcast on your favorite podcast client and on social media. It would help so much if you were also able to share the podcast episode you've enjoyed with a friend. Next, if you have the ability to do so, please do sign up as a Patreon member. Patreon memberships begin from just £4 or $5 a month, the cost of one coffee, and all Patreon members receive access to all of the video episodes, as well as receiving all episodes 1 week earlier without any adverts and other member benefits. Go to patreon.com/longcovidhope to learn more. And through this financial energy, we can buy better equipment, create a long overdue website, possibly get someone to help with marketing outreach, and of course, have time to allow me to do many, many more episodes. In fact, I will pledge right now that if we can get to 50 Patreon members, then I will give 1 day a week to this year round and have seasons lasting much, much longer than the current format allows. Lastly, putting my long haul yogi hat on, listeners to the podcast receive the discount code HOPE Podcast. That's discount HOPE Podcast, redeemable on all long haul yoga classes, yoga memberships, and remote Reiki sessions. Go to learnitlive.com/long haul yogi for all my live classes and recordings of live classes, and go to longhaulyogi.subkit.com for my on-demand yoga, Reiki, and meditation memberships. These are all designed specifically for people with long COVID and other related chronic conditions like POTS and ME/CFS. All of the Yoga for Long COVID series is very gentle and focused on listening to your body and going at your own pace. After having over 500 long haulers attend my classes, I'm happy to report exactly 0 PEM, that's no PEM whatsoever. So I do believe it is perfectly paced and suitable for all. And for complete beginners to yoga, you're also very, very welcome. Lastly, wherever you are in your long COVID or chronic health journey, know that things can improve. You can recover, you can make gains. Recovery is gradual and often non-linear. Keep the hope alive. Speak to you next time.